Sorry, you just caught me having a little sip of green tea. Hi everybody, welcome. Come in if you're joining us live. Hello. I can't actually see if people are joining, so I'm just saying hello anyway. But we always put all of the episodes of Probably Nothing up on our social channels and website to watch after the recording. So if you're watching this on catch up, I love you just as much as the live lot. Hi everybody, welcome to Series 7, Episode 2 of Probably Nothing, the weekly live online series from the Eve Appeal. My name is Karen, but I'm a nice Karen, I promise. I have to say that every day. I have to justify myself every day of my life. I work for the Eve Appeal, the wonderful gynae cancer research charity, and we started Probably Nothing in June 2020. And the wonderful Disruptive Media who do all of this streaming and broadcasting and setting up all for free for us, so thank you, Disruptive. They don't pay me to say that either. I'm genuinely grateful. We were all backstage a second ago and they said, right, Karen, let's go. Nice short intro, and I'm doing another long intro. I can feel it already. But even though we've done the 7 series of this, if you're watching this for the first time, you might not know what Probably Nothing is, so I'm going to quickly tell you. So started Probably Nothing in June 2020 because we wanted a sort of a safe and expert and easy to access way of getting lots of different gynae queries and questions and topics discussed in a forum, and also getting your questions answered. And so the Eve Appeal part of what we do is we run a free information service called Ask Eve, where people can call or email any type of gynae cancer question or concern. And lots of questions that we were getting from people would start with, oh, you know, it's probably nothing but, and then they go on to ask their gynae health query question. And most of the time, luckily, people's questions about gynae cancer don't end up actually resulting in them having gynae cancer, which is good. But for about 60 people every day in the UK are diagnosed with gynae cancer. So sometimes my little catchphrase for this is, for some people, that probably nothing is something. So yeah, we wanted to create this space, have a different topic, a different theme each series, and get your questions answered. I interview experts on whatever subject we're talking about, and we get the information out there. So this series 7, is all about the menopause. So last week we spoke to the wonderful Dr. Bella, a GP, about symptoms of the gynae cancers and what to expect and how to notice things and what to do when you're already past the menopause, you're postmenopausal. So most gynae cancers, apart from cervical, are more common in people that have gone through the menopause. And this episode is kind of the reverse of it, and it's talking about going through early menopause, what to expect, how to cope with it, going through early menopause as a result of having a gynecological cancer. So when having a gynae cancer means that you go either surgically or chemically into a permanent or temporary menopause. So that's the topic of today's discussion. I suppose I'll bring in my guest, who we've just been having we've been quite nasty to each other backstage, but only in the way that kind of like best friends can be. Come in, Tracie. Come in. There she comes.
Karen, here I am.
Tracie. Honestly, like if anyone's watched more than one episode of this, they'll be like, there they are again. So this is Tracie, our wonderful Ask Eve specialist nurse who splits her time with Eve and the NHS. Tracie is, I say this to everybody, I even said it to Bella last week, but I always say, oh, you're my favourite person, or I love interviewing you. I really love interviewing Tracie just because we're such good friends as well as colleagues that we just don't care. We just get to it, don't we, Tracie? I was being horrible to her about her sun exposure before we went live because I've just come back from 2 holidays. Oh, life's for living. And she was like, you don't look very tanned. And I was like, well, I put Factor 50 on, unlike some people. Tracie, be nice to me. I'm sorry.
And I still love you, sweetie. But the main reason I'm wrinkly is because I'm menopausal, naturally menopaused at the age of 52. I think I'm menopaused. Anyway, you're the one asking questions.
Right.
Yeah,
so, of course. So we're going to talk about, as I said, going through the menopause because of a gynae cancer. So not postmenopausal symptoms that people should look out for, but if you are under. So can you first of all, just for people that aren't sure, say first of all, what menopause is, and then I've been speaking about early menopause with regards to this subject. So can you just kind of give the sort of recap of what early menopause is and menopause in general? What does it mean?
Yeah, so menopause is a normal state for all women around about the age of, the average age, no woman is average, we're all super special, aren't we? But if we had to pick an average statistical age, women menopause at around about 50, between 51 and 52. I menopaused about 52. Karen, I'm 60 now. We might as well out it because you'll bring it on at some series. So there we go. So, and menopause is not a disease. It is a natural state for women around about age 51, 52, when their ovaries fail naturally. They stop working. That's the thing it's meant to be. So therefore, the unnatural, if you like, or early menopause is a menopause before the age of 51, 52, that is caused either by what's called iatrogenic failure, which means we don't know what causes it, or, as we're talking about today, caused by treatment related, caused by an outside effect, an exogenous effect that could be cancer treatment.
So can someone who's 38 go through an early menopause because they're under the average age of 50, early 50s? Can someone who's 38 just go through menopause without having gynae cancer? So naturally just go through an early menopause?
Yeah, you're absolutely right. And that would be called an early menopause, but it would be a natural occurrence for her. And that does happen for some women, and we don't know why. So that's called iatrogenic in the medical term.
That's what that was. Okay.
Yeah.
So you can't kind of give any sort of top line advice on how to stop yourself going through a natural early menopause or anything. There's no reason, there's no way to know if it's going to happen.
No, and it's one of those sort of urban myths that we often hear. In fact, one of my gynecology consultant friends went through an early menopause at the age of, oh gosh, she was late 30s. And that's where I've got a lot of my menopause advice and interest from, because actually she realised what it felt like. She went through it. But actually, she will tell me there's a lot of urban myths out there that says, well, if your mum menopaused early, you'll menopause early. If your mum menopaused late, you'll menopause late. It's not a thing.
Is that sort of
just don't know why.
Because people are like, oh, my mum had bad periods and I have bad periods. Like, is that?
It's not a thing. It's just, again, where usually the first people we talk to about is family or friends as well, but family, and they talk about their period experiences. So that's the first way you learn it. So that's where you kind of think that's what's going to happen to you, but it's not a thing.
No. And so we're going to speak about the gynae cancer angle rather than the natural. I hate the word natural and unnatural, but we'll use it.
Yeah, you're quite right. Yeah.
So I said at the beginning, like, apart from cervical, womb, ovarian, vulval and vaginal cancer are more likely to occur when someone's gone through the menopause, right? So apart from cervical, they're more likely to happen in people 50s, 60s, 70s, 80s, 90s. So when someone gets a gynae cancer, and let's just say under 50, because the average age is menopause sort of 50, 51, 52. So if an under 50 gets a gynae cancer, and then we'll talk about the different gynae cancers in menopause within those treatments. But how you've spent many, I was going to say many a year, but I'll say many a decade, as a gynae oncology nurse specialist. So people's gynae cancer nurse, basically. How likely is it that if an under 50 is diagnosed with a gynae cancer, that they'll go through menopause? Or is that a really silly, too broad a question?
No, it's not really silly, too broad a question. So I think what we should do is go through the different, what I would call tumour sites, what we in Eve call the different gynae cancers. Yeah. So let's take the cervix.
Yeah.
Your favourite, the one that you know more about than anybody else at the appeal. She's our expert. She's our super expert.
I never want to bring it up. It's not about me, Tracy, but I have had cervical cancer, yes. But I didn't go through the menopause. And I feel really lucky. And sometimes people talk about like the cancer hierarchy and stuff. And I'm really not making this about me, but I do sometimes feel guilty that my surgery and treatment didn't involve me having to go through the menopause on top of having cancer treatment, you know, because lots of people do go through it and struggle with it.
Absolutely. And so using your example with cervix cancer, it depends on how the woman is treated. So you had surgery and you didn't, thankfully, have to have radiotherapy or chemotherapy.
Yeah.
And the surgery removed a large part of your cervix, left you with your uterus, didn't touch your ovaries.
Mm-hmm.
So surgically, your ovaries are intact and not tampered with. So you're not going to menopause because of that. You didn't have radiotherapy. So radiotherapy, which kills cells, that's the intention. We target it to kill the cancer cells, depending on the tumor site, depending on the type of cancer. You didn't have radiotherapy, so that hasn't affected your ovaries. And chemotherapy sometimes we use in cervix cancer as a combination with radiotherapy. That can also kill off the ovary cells. The reason
Tracie, this is very unprofessional of me, and I hope we don't get fired. Are you on a laptop?
Yeah.
The signal is terrible for me. I don't know what it's like for people watching because I can't tell. Are you able to move, or is that an awful question to ask whilst we're live?
Well, I can move, but I'm very near the router.
You're near the router now. Okay, Lydia, our lovely comms manager, is on the chat. She says it is bad. Is it bad? Lydia says it's a bad idea. Oh, she's saying it's a bad idea, not that it's bad signal. Is that what you mean, Lydia? Bad idea, not bad signal. Okay. Is there any point asking you? Sorry if people.
I can try. I tell you what. I'll answer the question. Gosh, this is exciting.
It is exciting, isn't it?
We'll move downstairs. Okay.
But keep me on with you. Don't log out.
I won't cut you off, and don't anybody look at my knickers as we go past with the washing. Okay.
Let's just see. This is live theatre, people. Let's just.
Okay.
I just want to try it.
Whilst we're doing the live theatre, the reason that you didn't get an early menopause is because you didn't have your ovaries affected surgically, you didn't have radiotherapy to your ovaries, and you didn't have chemotherapy to your ovaries. I have to look down because I'm going down steps, everybody, and you don't want a risk assessment done at the end of the show. So that's why you didn't go into an early menopause.
So because my ovaries weren't touched, that's why I'm still having periods.
Precisely. But for women who have radiotherapy and chemotherapy as part of their cervix cancer treatment, there is a potential. Now there's the ironing and the washing, everybody. This is exciting, isn't it?
That's exciting.
There is a potential, washing rack. There is a potential to go into an early menopause. Okay. Right. So basically what we're talking about is the treatment induced menopause is due to the treatment a patient has. So moving on to womb cancer, for example, if the womb alone is removed and the ovaries are left, and that's for women that have an early have a cancer before menopause in womb cancer, which is quite unusual. But we do know people who do have a womb cancer at premenopausal age. If their ovaries are left intact, are left behind, just as yours were in surgery, then she won't menopause unless she has radiotherapy.
Sure. So it's rather than like obviously we'll talk about ovarian cancer, which is different in a minute. But Tracie, don't worry, we've seen it all already.
Too late, isn't it?
Ben and Lydia, if you're watching this and it's better or worse, your end, let us know in the chat. We're trying to be professional. We're trying to help people, but also trying to be professional. So it's more. We'll talk about ovarian in a second, but like with womb and cervical, it's not so much really the difference between the disease of womb cancer and the disease of cervical. It's just about at what stage it's found and whether that means your ovaries need removing, rather than womb cancer is this different disease to. Oh my God, I've gone in the dark as well now because I haven't moved. Hang on, I'm on sensor lighting. Hang on, let me just wiggle around. Tracie, say something.
Okay, so what Karen is detailing, she's quite right. It is not the cancer, it's the type of treatment that you have. So if you don't have your ovaries removed, if you don't have radiotherapy that affects your ovaries, in other words, that scatters or reaches your ovaries, and you don't have chemotherapy, which can kill off the ovarian cells, then you're not going to menopause. That's the basic premise.
That's the basic premise. And then we'll get into the different types in a minute. And going back to what I asked a few minutes ago, it like percentage wise, just because I don't know about people watching, but I love to know, and definitely when I was diagnosed I really was curious about how likely is it, the what percentage, etc. In your younger gynae cancer patients, do they, if you had to put like a percentage on it, how many of them would you say overall do end up going through an early menopause because of the gynae cancer? Is it kind of quite high?
That's super tricky, Karen, actually.
I know, I'm pushing, I know.
So, but carry on fishing, because our listeners want to know. So if our patient has a cervix cancer and it is advanced, then she's going to need what's called chemoradiotherapy. It is highly likely that she will menopause.
Yeah.
That's why we need to catch this damn disease early, because we don't want to be treating women that later on. It does, we can still get rid of the cancer that way, but we don't want to end up with the sequelae or the outcome of that treatment, which is the early menopause. Now,
so basically, unless it's caught early, the chances of you going through a menopause due to the treatment you'll have, because it's more advanced than an early stage, are very high, basically.
They are very high. I don't want to get too complex with this, but for any woman that is going through cervix cancer now, and we know how she feels, don't we, Karen? If she's going to have chemoradiotherapy, there are, in some cases, and everybody's individual cases, she can have, there's a surgical operation called ovarian transposition, where her ovaries are moved up out of the radiotherapy field. So they're moved by a surgeon.
So say they're like here, they're moved sort of where, like up here, or
underneath your rib. Yeah, okay. They're moved there.
Okay.
Yeah. So, gosh, you have lost weight, haven't you? And and also the ovaries can be what we call turned off. In other words, we can use a drug. It's like a depot, like the contraceptive that we have, that sort of puts the ovaries to sleep temporarily so that the chemotherapy doesn't affect them. Now,
is that only if they're moved, or can they stay where they are and have the depot, or is it like, oh, you move them and have the depot?
They do both. Now, that doesn't work for everybody, so I don't want anybody listening thinking, oh, that's all right, it's fine, I can get sorted that way. But I think it's important to mention it for completeness.
Yeah. And okay, so I think you'll agree with this, but I definitely found when it came to being diagnosed whilst still menstruating, so pre-menopausal, that and luckily I was a late stage 1, so it was contained. So people watching, cancer stage 1, 2, 3, and 4, the higher the number, the bigger the cancer site, the more it's spread.
Yeah.
But would you agree? And we're doing a fertility episode next week, so we won't go too much into the fertility side of it, but just with regards to surgical menopause, would you agree that when someone has a gynae cancer and is pre-menopause, so still in their fertile years, that obviously the health of the patient comes first, but doctors do try and preserve fertility if possible? So if there's an option to not induce menopause, that option, as long as it doesn't affect, as long as it's not like, oh, Karen's more likely to not have her cervical cancer sorted out, they will take that option to preserve fertility because they want that
absolutely. Yeah, absolutely. And every case, every person is unique. And so every woman in this situation, if we're talking about whatever cancer she has, we need to counsel her, and so that she consents and she looks at the risks and benefits of the surgery that she's having. And she may want to take a small percentage risk of less chance of the surgery or treatment being successful, in order to not compromise her fertility. And of course, you're going to talk about that more next week. So there isn't a one size fits all, and it should never be that way. It should be an individual conversation like you had with your surgeon.
And so we've spoken about womb and cervical cancer, and if your ovaries need to be removed because the cancer spread, or you need chemo and or radiotherapy or brachytherapy, which is internal radiotherapy, you will lose your fertility, go through menopause. With ovarian cancer, is that kind of more like a done deal, whereby, because it's the actual place that's affected, the place
You're
of defining.
You're absolutely right.
Yeah.
You're absolutely right. So with ovarian cancer, we need to remove the organs that are diseased. So that's a very medical way of saying, yes, Karen, if the ovaries have cancer in them, they need to go, along with other area around in the what's called the peritoneal cavity where the ovaries sit. So yes, surgically removing the ovaries means menopause. That we can't. Yeah.
And when someone has, well, whatever age, but we'll talk about a 38-year-old, when someone has ovarian cancer, do they have cancer in, because there's two separate ovaries, like you have two boobs, two ears, two ovaries. Do you have ovarian cancer just in your ovaries overall, or can you have ovarian cancer in one ovary and keep the other ovary, or do they kind of want to take both out because one, if only, or can only one be affected?
So that's that very, very, so generally both ovaries, it will be recommended depending on the type of ovarian cancer. So there are a few different types, which we've talked about before, but sort of just to give you an overall kind of view. So if you've got the standard, and I don't mean to be reductive with this, but if you've got a high grade serous papillary, which is about 80% of ovarian cancers, even if it's only seen in one ovary.
Yeah. And is it more likely that it is going to be just seen in one ovary? Is that more common?
Well, the thing is when we say see, the picture that we're seeing is a clinical picture. So we don't do a biopsy of the ovary.
Why not?
Because we don't want to have what's called capsular spread. We don't want to sort of, we don't want to, if you think of the ovary like an egg, you don't want to crack the shell and let the contents, if there's any cancer in there, fall out into what's called the peritoneal cavity. I'm not going to stand up now amongst the washing, but it's from
you'll lose you in your knickers.
Rib cage, yeah, exactly, down to the so the peritoneal cavity is from our rib cage to the sort of to where our pubes are, if you've got pubes, but that area of your body. So what we don't want to do is take biopsies of the ovaries, because
it can really, but like if you burst the bubble or crack the egg, it can cause the cancer to spread. So it's kind of like you want to take the whole ovary out because it's got the yolk, the cancer, whatever you want to call it, inside it.
Exactly. And so what we tend to do, what we do is it's a coincidental finding. If an ovary is being removed, we're not expecting cancer. She's young. We tend not to see it in the younger generation.
Why would you be removing it then?
Because she could have a big cyst in there.
Okay, fine. Yeah.
Which is causing problem on ultrasound. It will look, so that's imaging. That's like the ultrasound that you see when you see somebody who's pregnant. Or a better ultrasound is where it looks like a vibrator, but without the fun and a battery in it, and that's got an ultrasound tip to it, and that's the best way.
I've had an internet. Yeah, they're not fun, everyone.
You know exactly. Yeah,
if you want a good time, don't go for a TBU.
Exactly. So if her ovary looks on balance that it might be a cancer, but can't be 100% sure, and she, as you say, we have a spare.
Yeah.
And that ovary may be removed. This is on that individual case basis again. If that ovary is found to have cancer in it, then a conversation will ensue with that patient as to the likelihood of a cancer being in the other ovary. And if that ovary is removed, then she'll go into an immediate surgical menopause.
How likely is it that the 38-year-old with the ovary out, gosh, there was some cancer in that ovary, Miss Smith. How likely is it that she'll end up with both ovaries out? Is it likely it'll be in both?
It's very likely. It's very likely, but once again, it's tricky to get into the minutiae. Every case is different, but yeah, it's
if
very
we had to, I mean, I don't know if people watching hate the sort of general sweeping or love it. I kind of sometimes like a general sweeping to know, like, if you're more or less likely, but obviously we expect to say everyone's individual. So it's fairly likely if you're a young person with ovarian cancer and you have one ovary removed, it's quite likely you'll end up with both ovaries removed.
Yeah, we ought to put the caveat in there, and then what we'll do is we can always take questions at Ask Eve or to the service, because there is a type of ovarian cancer called low grade.
Yeah.
And it's still termed as an ovarian cancer. It's called low grade, and it's classed as an ovarian cancer, and it technically is. But in some of those cases, our patient, doesn't need to have chemotherapy, and they may well monitor her.
Okay.
Spare ovary, if you like. But it's a tricky one, because I'm giving an overall sweeping and that's the sort of thing where at ASCII we can really go into individual cases and help advise. Yeah.
So going back to kind of surgical menopause. Well, also, so we've spoken about the womb, cervical, and ovarian, vulval and vaginal. So the canal, the vagina's on the inside. Everyone remember, it's got the word in it. Don't know how I haven't paid £1 million for that phrase yet. And then the vulva, all the external female genitals, from your pubic hair all the way down to your bum hole. If you have a disease there, is that because it's lower down and further away? Like the vagina and the vulva are further away from the ovaries than the womb and the cervix. Yeah. Is it a silly question? Like, is it less likely you'll go through the menopause if you have a lower down gynae cancer?
No, it's not a silly question at all. You're absolutely right. So let's think about the treatment.
Let's go vagina first, because we'll go from the inside out.
So vagina, if the surgical option is to remove some of the vaginal epithelium skin, but not the ovaries, then our patient isn't going to menopause before the natural age, before that age of 51, 52. If, however, she has chemotherapy or radiotherapy, then there is a potential that she may well menopause. Chemotherapy goes all around the body. It's called systemic therapy. So there's a likelihood.
It's not targeted to one area.
No. So there's a likelihood.
You have chemo or you don't have chemo, sort of thing.
Exactly. So there's a likelihood, therefore, that it'll go through her ovaries. It will go through her ovaries and therefore induce a menopause. If she has radiotherapy, it depends on what we call the scatter of because radiotherapy is targeted. It's targeted to the area, in this case, an area of the vagina. So generally, a menopause doesn't ensue after vaginal radiotherapy, but we can't guarantee that. And then moving on to from the inside vagina to the outside, the vulva. I'm learning. Got it right after all these years. Got there eventually. Same principle applies. So surgery, if her ovaries aren't being touched by vulval cancer surgery, which they won't be, she's not going to go into an early menopause. If she needs chemotherapy, that's going to be systemic. That's going to go all around her body. So she is likely to menopause. And radiotherapy, once again, probably won't menopause due to the radiotherapy, but we can't guarantee that. It depends exactly on, when I call scatter, that makes it sound not technical and they don't know what they're doing.
But going for it.
Yeah, it's not 100% guaranteed. So once again, it's that kind of get yourself checked as soon as you can. So if you do have a cancer, which is what we're all about, then what you see is probably nothing, as you say. But if you do something, get it checked, and you don't know you don't need those treatments other than surgery to get rid of the cancer.
And so the temporary menopause, where the ovaries are kind of temporarily shut off or moved away, like how are they kind of, if they're moved out of the way, why would they need to be shut off? Because surely they're out of the way, so they're not going to be hurt.
So you've got this double protection going on and this is when we're talking about a young woman with cervix cancer. And this is a woman.
And womb as well, or not?
And well, no, with womb, transposition of ovaries won't work because the radiotherapy is too close to we can't move the ovaries far enough away. I'm doing all of this as though that's really going to help. Yeah. So it's with the cervix cancer. So if we move the ovaries up as far away as we can, literally, we can put them underneath the rib cage there. That's moving them out away from the radiotherapy field. So that's one way of trying to preserve ovarian function, keeping them alive. The other thing is she's likely to have, our patient, if she's having radiotherapy, she's likely to have chemotherapy too. It's called chemoradiotherapy.
Is that because both together are better, or because that particular cervical cancer is a disease that responds better to both, or is that just for every cancer?
Well, no, so it's because it's called chemoradiotherapy. The chemotherapy actually makes the cells more sensitive to radiotherapy. So the combination of the two actually works better. So it's called it's known as a radiosensitizer when you have chemotherapy and radiotherapy.
Do you know, some of the questions I ask, I already know the answer to, but I'm making it so it looks like a natural conversation. Oh, look, a peek behind the curtain, everyone, as to how we do this. But I genuinely didn't know that.
There you go.
That's really interesting. Okay, so it kind of like preps the cancer, so it's
yeah.
That's so interesting. Okay,
yeah. So we need to move the ovaries out the way of the radiotherapy field. So that's physically getting a surgeon to move them out the way. And then we need to protect them from the chemotherapy that's going to sensitize the cervix cells and make the radiotherapy work better. And that's why we put the ovaries to sleep, the depot injection, because chemotherapy acts on quickly dividing cells. The ovaries have quickly dividing cells when they're busy doing their cycle. Yeah, exactly. So you turn that quick off and flatten them, and hopefully that will help to preserve the ovarian function.
And so if someone through cervical cancer goes through or into a temporary menopause, from how you just described, like how long can someone expect after their treatment for the ovaries to be woken up again?
So it depends when the depot drug runs out.
Okay. So it's not like it has to be 3 months after you finish treatment, then you can knock on the door and wake them up again.
Yeah, exactly. It's basically when the depot injection runs out. Then we've got to remember the stress of going through cancer treatment, the anxious, and all of that stuff, which stops periods anyway for women. The thing to remember for our cervix cancer patients is it's not always offered the moving the ovaries.
I just wanted to cover kind of like the permanent and temporary side of it, but it's not that you'll necessarily, unfortunately, get a choice as to which you go for. So let's talk about like how one might feel or how to cope with actually going through it. So say a 38-year-old's got ovarian cancer, has the ovaries out in a surgery. They wake up. Do they obviously, like, they've had the physical cut surgery, open ovaries out, but like, will they feel? We speak about menopause, and we spoke about it last week about the kind of like the hot flushes, the sort of maybe like irritability or forgetfulness, the body temperature, all of the menopausal symptoms. Will someone wake up from an ovarian cancer surgery or any surgery to remove the ovaries and feel menopausal like that? Is it that quick, or does it take a while for your body to sort of think, oh, this has happened to me?
It's not usually that quick.
Okay.
So, and what we often say for women is, let's get you over surgery. So that post-surgical period, you remember what that feels like? You just feel bleh.
It's gross. Yeah, it's horrible.
And then we tend to say to women, give it about 3 months and see how you're managing. And then we'll look at finding the right HRT for you. In fact, we've got a question about HRT. I've just seen come in, but I'll wait for you to have a look at that one, Karen. But so we tend to say, just wait a couple of months post-surgery, because one of the side effects of HRT can be...
combine both answers. Is that the same for a chemical menopause as well? So say the chemo and radio essentially killed off the ovaries. Is this the same as well? Wait till you're up.
Because we kind of want you to be washed out or have the treatment washed out and away from you. There's the chemotherapy or to get over surgery, and then we can look at your new normal minus cancer normal, and then look at organizing your HRT for you.
And if someone, so say you, when you went through your menopause, a natural menopause at the age you'd expect to go through, and the 38-year-old from a gynae cancer, like if you took both of you at the same time, is the gynae cancer patient gonna, apart from actual gynae cancer treatment, let's, if we can, it's weird saying this, but ignore the gynae cancer stuff, the menopausal stuff, is it because it's unnatural, it happened before it should have, again, all the air quotes, I hate all those phrases, is it worse for that person than it was for you at 51, 52? Like, is it more, is the vagina, we spoke about the vagina getting dry last week, is the vagina drier and sorer? Is the mood, is it drenched in sweat rather than a bit sweaty? Is it terrible sleep rather than bad sleep? Is it serious mental health issues rather than not unlikely to feel depressed? Like, is it much more extreme?
So everybody's different.
I'm asking you all the, I know, I'm annoying with the questions. I know I am.
Yeah, and I'm giving you a 50 Shades of Grey answer, which isn't very helpful. So every woman's going to menopause. Every woman's menopause is different. About 50% of women who, I too hate the word natural, who menopause at the age of around about 50 won't have any issues at all. Similarly, women who go through an early menopause due to treatment for their cancer, anecdotally, and I've listened to tons of women over the decades, as you say, yes, they do say that they find their menopause, because they come crashing into a menopause. It's not a gradual.
Perimenopause with Bella, like years of not easing into it, because I'm not trying to, again, like you said earlier, being reductive with it, but it's not this, your ovaries aren't whipped out, they're gradually shutting down.
Absolutely. And actually, the question that we got in, I was just reading it, Karen, so I was going to bring it up. So we've got somebody who has the BRCA2 gene, often known as the Angelina Jolie gene. So that's, we've got BRCA1 and BRCA2 gene, and hers is faulty, which means it increases her risk of getting breast and ovarian cancer. So what she's done is she's had risk reducing surgery, like Angelina Jolie did. And this girl is struggling, she tells us, with menopause symptoms, and she's worried about osteoporosis. Can she take HRT?
Yes. My ovaries have been removed and I've had a double mastectomy.
Exactly.
We'll ignore the mastectomy bit just because it's with breast and we're ovary. Obviously, it's not to ignore, but you know what I mean. Yeah. Is it okay to take HRT? Yeah. So let's talk about, because she's worried about menopause symptoms and osteoporosis risks. So let's talk about, I did have it on my list, Tracie, but you've jumped the gun, but that's okay. That's okay. I'm not holding back and I don't care. So let's speak about treatment for, so to wrap up what we just spoke about, anecdotally, someone going through menopause at 52. Oh no, I've gone dark again. Hang on. Oh, absolute chaos. Someone going through menopause at 32 to 52 because of gynae cancer versus naturally is typically, anecdotally, more likely to have a more severe reaction, have worse symptoms.
She is, because it's a sudden menopause, and we can't, although, like we said, put the thing to one side, actually she's gone through cancer as well. I mean, it's double whammy, and coping mechanisms, the whole shebang, it's a lot harder.
So now let's talk about, so we know that menopause, or people might not know, what else can menopause impact? So going through menopause, it's not just, oh, your ovaries aren't working, is it? There's other areas of health to be concerned about, like this question is asking, to consider risks over.
Yeah, exactly. So menopause at the age of 50, 51, we accept that, and some women will take HRT, hormone replacement therapy, that's estrogen and progesterone. But if a woman menopauses, either because of cancer treatment or the surgery that this girl has had to prevent getting a cancer in her ovaries and her breasts,
which, as far as menopause is concerned, is the same as if she'd had ovarian cancer and had the ovaries out because of it.
So she's had them removed exactly early. So up to the age of the natural age, as we said, with the air quotes, of around 51, 52, we would advise her to consider taking HRT. This is general again. Everybody should speak to their team, because HRT protects against osteoporosis. That's the thinning, having brittle bones.
Which is what this person has asked about. They're worried about.
Exactly. It's also known as cardioprotective, so helps with heart health. It also helps with bowel health, keeping your bowel healthy. It also helps with cognitive health, our brain health, not getting the brain fog.
There's such a correlation, isn't there, between people being prescribed antidepressants when they go through the menopause.
Exactly. So absolutely, it is generally, in the majority of cases, safe to take HRT after risk reducing surgery. that this lady's talking about. And actually, I would have hoped that she'd been counselled about that before the surgery, but she's talking to us now, and we're more than happy to take more questions and ask Eve. But yes, she should be considering it.
And when it comes to, so is it just the BRCA gene alteration that is the genetic thing that can make someone, if they have the surgery, go through risk-reducing menopause, or is there anything else genetic condition-wise that can put someone into early menopause that we need to include?
You've been doing your homework again, Hannah, haven't you? Yeah.
I'm asking like such loaded questions. I'm like, say this answer.
So what Karen is alluding to is something called Lynch Syndrome. Karen made a fabulous suite of videos on the website if you want to have a look. It's called Let's Talk Lynch. But Lynch syndrome is another inherited risk predisposition syndrome, a genetic syndrome, where in this case the woman is at more of a risk of getting a womb cancer, ovary cancer too, though, as well, as we alluded to in the videos that you made, Karen.
But so womb and bowel more likely than ovary.
Exactly. So if our patient has risk-reducing surgery, in this case, she's likely to have her womb and probably her ovaries removed. And exactly as you say, Karen, it'll be the same thing if she's before premenopausal age, before the age of 50, 51, then we'd be looking at advising that she had HRT.
And just to wrap up, because we've only got a couple of minutes left,
okay.
Unless there's anything else in particular you want to say, but let me know in a second. So say someone has had either risk-reducing surgery or treatment for gynae cancer. So whether it's a surgical chemical menopause for whatever reason, gynae cancer related, like so say that's happened, will their cancer team help them with the menopause post-surgery, or is there a specialist person to talk to? Does their nurse, does their Tracie, their gynae cancer nurse, send them to someone? Do they go back to their GP? Like if someone's thinking, I've got this coming up, who do they go to for help with this?
So there are more and more menopause clinics becoming live, if you like, in the NHS. It's an absolute must that we have more menopause support clinics. And Macmillan, the cancer charity, are actually helping to support a lot of nurses to train as menopause within or because of cancer clinics. You can go online, and if you look at Google Menopause Matters, that will give you a sort of like a heat map of around the country of menopause clinics that you can go to on the NHS. So they're not everywhere.
And it's not automatic as part of your cancer gynae oncology package, like at your hospital or whatever, that whether you're having your surgery or your chemo, that they'll then help you with managing menopause afterwards. And I'm not slating the cancer teams for not doing that. I'm just asking if where can they expect to get that help from, you know?
They should expect to get it from their gynae cancer team, from their CNS, their nurse specialist, who, if they're not trained in menopause management or don't know enough and they should be able to signpost, which is a very sort of medical nursey terminology, where the patient should go, most definitely.
And just to kind of wrap up with some tips and things to help people. So what can people do? What helps people manage their early menopause? If someone's struggling, what can people do to help themselves or you know, rather than
absolutely. And also apologies from the washing and ironing cupboard. There is no light for me to put on, but I can shed some light on. Isn't it funny?
Very good.
Talking to you from my ironing cupboard.
Yeah.
Daisy Network, put that into your Google browser, anybody who goes into an early menopause. So this is the signposting side of things. And there's a whole sort of club of women who are, so that peer support, that's really, really important. Ask Eve, we will always help signpost as well. Menopause Matters, that's another one to put in the Google browser. And that will give a lot of support and advice on how to manage symptoms, but it's things like
alleviating symptoms, you know, like if people are feeling really
so the hot flushes, There's things like it's the same advice that we give to women of my age going through menopause, things like the Chillo pillow. So there's pillows that you can buy that actually you can sort of put like instead of like a hot water bottle, it's the reverse. You can put a thing in the fridge and that makes it cool. Not wearing tight clothing, using a fan, reducing tea, coffee, alcohol, chocolate, not necessarily all of those things, Karen. So you don't have to panic for your age 50s. Yeah. We will get, I know. It's a while till you get there, darling. But every woman is different. So there's various different foods. Spicy foods set some women off with their hot flashes, or some people call them power surges. I can tell you when a woman's going through it, it doesn't feel like that. So I could spend another half an hour with a list of advice, really. And I'm thinking that's something we're going to need to get on our Ask Eve page.
So, okay, so there's, and what about just quickly things like maybe like the mental health side effects of not necessarily the gynae cancer, but going through the menopause at a younger age?
And that's really, really important. I mean, we've just come out of Mental Health Day, haven't we? And I'm not quite sure how much was mentioned about menopause and how we support women. So there is, from NICE guidelines, the NICE guidelines, National Institute of Clinical Excellence, the menopause guidelines, they do recommend CBT, cognitive behavioral therapy, and that is useful for some women. Some women are given very low dose antidepressants, and that can make a difference. So, the mental health side of things, I do think GPs and definitely the cancer teams are more familiar with that support. But I also understand that a lot of women aren't getting that. So if they're not, do come to Ask Eve and we can signpost.
Okay. We'll wrap up there. But Tracie, go into the green room and I'll say bye to you in a second. Thank you very, very much. Bye. Okay, so I mean, like last week with Bella, we could go on for 3 times as long than we have available to us on air. So thank you so much to everybody for watching Series 7, Episode 2 of Probably Nothing. Speaking to Tracie all about coping with early menopause as going through gynae cancer, or what to expect if you're going through early menopause because of gynae cancer. Next week, which is the 18th of October, we will be talking about fertility options and reproductive health. So that's again for people that have gone through menopause at a younger age because of a gynae cancer. So thank you again to everyone who's watched live. If you're watching on catch up, thanks so much for taking the time to catch up with this chat. Thanks Tracie. I'll say bye to her properly in a second. And thank you to you all for always supporting us. We wouldn't have Probably Nothing if people didn't engage with it. So thanks again and see you next week.